lot of kids that are on both Seroquel and Abilify in their adolescence.
Yeah, that's now there are some studies that are coming out. Well, there are studies about using 2 different antipsychotics. Most of the studies show that there's no benefit. You just should maximize one antipsychotic over the other, okay, dosage-wise. That being said, there's always exceptions, and we have really difficult cases where the kiddo, if you go too high on one antipsychotic, it causes significant side effects. So you try to combine the 2 antipsychotics to get a better effect over mood stabilization, right, and the psychotic symptoms mainly, with less side effects, okay? Now, the other thing is, Seroquel is not FDA approved for sleep. But Seroquel has 2 forms. It's the XR, which is the extended release, and the rapid release, right? The immediate release. The immediate release with Seroquel, the lower the dose, the more sedation it produces, okay? So it's really bizarre. If you go up to 300 on Seroquel, it's gradually, they're actually less sedated than if you go from 50 to 25, it knocks them out. So sometimes we use the antipsychotic, for example, Abilify, at higher dosages for mood stabilization, and we use the 50 or 25 of Seroquel to help them sleep and knock them out at night. So they're used for 2 different purposes, okay? But you will always be asked, why are you using 2 antipsychotics? And when we discharge a patient, we give an explanation of why we're using 2 antipsychotics. Because of the risk of metabolic syndrome and the risk of well, mainly because of the risk of metabolic syndrome. Okay. Any other questions about antipsychotics? So we're building our treatments. Medication treatment, first line would be the antipsychotic. Okay. But we don't want to have to use the antipsychotic for a long period of time if we don't have to. Okay. And we want to avoid all the side effects. Then we have the mood stabilizers. Mood stabilizers do not cause metabolic syndrome. Okay, as far as the research says, or we've seen. Mood stabilizers do not cause EPS or tardive dyskinesia, right? So we want to be able to use the mood stabilizer for the long-term treatment of these kiddos. So we've now given them the antipsychotic, they're a little bit more stable. Now we're going to try, they're on maintenance, let's say, they're in a safe phase, they're outpatient. Now we pick a mood stabilizer, which is the seizure medication. Even though lithium is a fantastic mood stabilizer, it can affect the heart, it can affect the thyroid and make you hypothyroid, okay? Lithium, you have to get levels on lithium because you can become lithium toxic. When it's toxic, it affects your thyroid more, you become disorganized, you can get confused, delirious on the lithium. So you have to get blood levels on it. It can make you really tremulous and basically not do the job if it's too high. It can affect your kidneys also if you become lithium toxic. With kids, so lithium is not obviously the first line, even though in adults it is the recommended. Depakote and lithium are the recommended mood stabilizers because of the research, because it is very effective. But I try to leave lithium as one of the last ones because of all the potential side effects. Lithium can also cause defects in the fetus. If you have a teenage girl that is bipolar and she becomes hypomanic, manic, hypersexual, goes out, gets pregnant, lithium is not the medication you want her on, okay? Or the other mood stabilizers, but lithium is one of the most teratogenic. Then we have Depakote. Depakote is a very good mood stabilizer. You also have to get levels on it, blood levels. Depakote can affect the liver, so you have to follow the liver enzymes, right? With Depakote, you can increase the appetite significantly. So even though it doesn't cause a metabolic syndrome, you can increase the appetite. You have to be careful with what medications you combine with Depakote because it can cause what we call, certain mood stabilizers will make the other one get chewed up faster. It'll decrease the levels or increase the levels. Okay? So we have to be careful with how we combine the mood stabilizers, if there's a combination of those. Lamictal is another mood stabilizer. It's called lamotrigine, also very good seizure medication. But what we need to watch out for with this one is a drug reaction. a drug allergy. Now, you can have an allergic reaction to anything, and you have to pay attention to it. But lamotrigine can cause one that's very quick and fulminant and can get very complicated and end up in hospitalization. So it's a medication we go very slowly on. Actually, all of these are pretty slow. As well as trileptal, it's another mood stabilizer. Trileptal, for me, it's kind of a hit or miss. Fantastic when it works, but it doesn't always work. But you don't have to get blood levels on it. Sure, you can have an allergic reaction to it, but it's not that common, right? It's not terribly sedating. It really doesn't increase the appetite, so the side effect profile is fantastic. But it's not as effective as the other ones. That's my observation in the clinical practice. I do try it first, because with that kind of side effect profile, why not, right? If they're already stable on the antipsychotic. Any questions about these mood stabilizers? Okay. When are antidepressants used? Now, if you recall, we spoke about how the first presentation of bipolar disorder could possibly be a depressive episode, right? Or major depressive disorder. You don't have any signs of mood disorder or bipolar disorder. You have a teenager that comes in for depression, right? But thankfully, we don't have only that presentation or that symptom. We already know that parents are bipolar, or there's been individuals with mood swings, even if they haven't been diagnosed. You ask about mood swings, domestic violence, aggression, antisocial behaviors. There's other stuff in the family that might point towards mood disorder. If there's a lot of that, right, and very close, either in the siblings or in the parents or aunts or cousins, then you really have to think whether you're going to use an antidepressant. Because an antidepressant in a mood disorder or bipolar disorder makes things worse. Okay? Let's say the individual is depressed. So what happens is you start an antidepressant, and instead of feeling better, they're still depressed, they're super energetic, they're getting agitated, right? And then at that point, the thoughts they had of hurting themselves actually become more organized. So now they do have an intent and a plan, and they follow through. Okay? So the antidepressant actually makes them worse. Then you have to think, ooh, maybe this is a bipolar disorder. So you have to back off, right? You stop the antidepressant. You rethink the whole thing. Now, how are you going to catch this quickly? Well, you're supposed to take the child in within the first 2 weeks, right? So if you're going to get an appointment 3 weeks after starting an antidepressant, that's just not going to work. Now, to talk about the black box warning, you're going to see black box warnings on the antidepressants. Be careful, because antidepressants can increase suicidal ideation, suicide, right? If they're started. Well, that's kind of controversial, because if you are a child that is depressed and you are suicidal and your depression is not treated, there's a higher risk of follow-through on suicide. So, do you not then treat the individual, okay? The other factor is, if you're a child that is depressed and you're started on an antidepressant, but now you're going to your psychiatrist and your therapist, well, you're going to talk more about suicide, because they're going to ask you every time you come into the office, right? So you might feel even more comfortable expressing it, okay? The other thing is, the other way to look at it is, when you are depressed, there's that kind of that slow depression. There's really a lot of hopelessness. There's lack of energy. There's just not even energy enough to follow through on your plans or your ideas that you have. When you start treating an individual with antidepressants, the first thing that improves is their energy level, not their mood, right? So you can have a very depressed, energetic individual, which at that point will follow through, okay? The other thing is that sometimes as parents or as guardians, we feel that if they have gone to the psychiatrist, they now have a therapist, and they have started their first dose of medication, oh, what a relief. They're now going to be cured, there's not an issue. So the parent or the guardian kind of backs off. There's less vigilance at the moment where there should be the most, because you're talking about these things even more so, and then they follow through, or they attempt, Okay, so there's a lot of reasons why this kind of black box warning comes out. Is it only one thing? Is there a direct link between antidepressants and suicide? They can't say that. Okay, so, but there is a lot of different factors that when you do start an antidepressant, it seems as if there is more suicidal ideation. The counterpart to that is that when they came out with that black box warning, psychiatrists started backing off antidepressants, and then the suicide rate increased. Right, because of liability. So you don't stop, you don't not treat, you just have to treat appropriately and follow up appropriately, okay? The serotonin, the SSRIs, have a higher risk of inducing cycling and mood disorders, okay? So when you start an SSRI and they're already on an antipsychotic and a mood stabilizer, why would you start an antidepressant? Because mood stabilizers or antipsychotics stabilize, the cycle is like this, right? They have a dip, they're depressed. They're doing well or mixed or dip. So when you stabilize a mood, it doesn't mean that you're going to stabilize it in a good mood. You can stabilize a depressed mood. So now they're not going up and down, they're not aggressive, but they're just kind of depressed all the time. And yes, they think about hurting themselves, so they're here. You want to get them to euthymia, which is a good mood, right? And you need that little boost of antidepressant to work with the antipsychotic and the mood stabilizer to get them there, okay? That would be one of the indications. You don't want the kid to be stable for the rest of their lives. Depressed, stable though. I mean, what kind of a life? So, that's when you have to be careful which antidepressant you use. Again, the SSRIs can be used when you have that good foundation, but they have a higher likelihood of causing cycling. Then these are the ones: Prozac, Paxil, Zoloft, Lexapro, Celexa. And then we have other types of antidepressants that are not only serotonin reuptake inhibitors. These antidepressants actually have a lower tendency of inducing cycling, so you can use them, okay? With maybe less risk of causing cycling. And we have Wellbutrin, right? Wellbutrin and Cymbalta. Now, Wellbutrin has been used more in kids. Cymbalta is a newer medication. Wellbutrin also has been shown to help with ADHD. So you have a kiddo that you need to treat with, treat for depression, and they also have ADHD symptoms. Try Wellbutrin, right? Because you might not have to use a stimulant at that point, okay? Cymbalta is an antidepressant. It helps also with anxiety. It does not necessarily help with ADHD. You have to take into account Wellbutrin does not help with anxiety. It actually can induce a little bit of problems, increase anxiety. So you have to watch for that as well. Now, one of the other benefits of Wellbutrin is that it tends to decrease the appetite. So if a kiddo's on these medications that increases the appetite and then you have another one that decreases, that's a benefit, a beneficial side effect. And we already talked about the FDA warning about the suicidal ideation. Any questions about antidepressants? Yes?
So, we have all these different types of antidepressants. Do you find that some work better with certain types of depressions? For example, if you have a kid that's more anhedonic versus a kid that's a little bit more obsessive or irritably depressed, do you find that there's different antidepressants that tend to do better with those different types of sort of qualitative differences in depression?
Definitely, yes. Because, for example, you have, like we were talking about, the Wellbutrin. If you have a kiddo that's really low on energy, right, lethargic during the day, sleeps a lot, Wellbutrin tends to boost the energy. Right? So that's one of the medications when you're thinking about the different types. Okay? If you're thinking about a medication with an antidepressant for depression where there's a high component of anxiety and kind of obsessiveness, then you might want to think about Zoloft, right? Because that helps with more of the anxiety and the obsessiveness. If you have a child that has tons of medical problems and you really have to worry about drug-drug interaction, and we're not even talking about emotions or symptoms, we have to make sure that we use an antidepressant that doesn't interact much, then we're talking about Lexapro and Celexa, because their drug-drug interaction profile is very good. So if this child has a whole bunch of other medical problems and are, you know, on a list of other meds, then that's the safer way to go. Any other questions? Okay, benzodiazepines. Now, they're already on for the medication treatment. They're on the antipsychotic, they're on a mood stabilizer, and now they're on an antidepressant. So they're on 3 different medications, okay? Some difficult to treat patients need to be on all these meds. They're not going to respond to one or the other. They have to respond to kind of the mix of these medications, okay? The objective is to eventually be able to wean them off the antipsychotic and leave them only on the mood stabilizer. But if they're on an antidepressant, it's very likely that they're going to need to be on a mood stabilizer and the antidepressant, okay? Will they need more meds? They might. They might have such a high level of anxiety, you might have to use benzodiazepines. You have to be careful because these do produce addiction and tolerance. So you don't want to use these medications for a long period of time. It doesn't mean you can't use them though, okay? Some individuals with bipolar disorder have panic attacks also because it really increases their anxiety, so you use. But if you have a kiddo that has a substance abuse problem, you want to try to stay away from these medications that can be abused. Okay? So those are the other factors that you have to take into account. Okay, stimulants. I'm just going to go make a comment about this. If an individual has ADHD and a mood disorder or bipolar disorder, you don't want to start them on a stimulant first because it can make things worse. It doesn't mean you don't treat their ADHD. Now you've treated their bipolar disorder, they're actually calm, in a good mood, but they're still hyper and inattentive. You can treat them with a stimulant. You just have to, like in all situations with kids, you start at a very low dose and you see which one works the best for them. Okay, depending on the side effects. Sometimes you can't use the stimulants in ADHD. Sometimes you have to use the other type of non-stimulant medications like Strattera or Klonopin or 10X. The newer forms are Capvey and Intuniv.